Good afternoon, everyone. Thank you so much for joining us today. I hope you're keeping well, especially now during these very unusual times. My name is Michael Burns, and I'm President and CEO of the Princess Margaret Cancer Foundation. I'm glad to see so many people who have tuned in today for our final episode in our Future Forward series. Today, we will hear from Dr. Camilla Zimmermann and Dr. Sarah Hales, two highly respected physicians who are both members of the Supportive Care Department at the Princess Margaret. This department is dedicated to helping people throughout their cancer journey by providing programs and services that focus on their physical, emotional, and psychological needs. As we all know, cancer is still the #1 cause of death in Canada. And just as cancer will not relent during this pandemic, neither will the Princess Margaret. We are committed to keeping up the pace of discovery today and long after COVID-19 has passed. Before I introduce our speakers, I would like to thank you, our supporters, for your incredible support of the Princess Margaret Cancer Center. With your ongoing generosity and the incredible work of our world-renowned clinicians and researchers, we will continue to make great strides until we accomplish our mission to conquer cancer in our lifetime. There is a donation button below and on your Slido page. If you appreciate what you hear today, please do consider contributing to this very important cause. Now I would like to introduce to you Dr. Zimmermann. Dr. Zimmermann is world-renowned for her work in palliative care and supportive cancer care. She is head of the Supportive Care Department at the Princess Margaret Cancer Center and a senior scientist at our research institute. Dr. Zimmermann has been internationally recognized for her groundbreaking research on palliative and supportive cancer care, particularly in the area of early integration of palliative care. She has contributed to the international recognition and growth of our supportive care department through a robust clinical, research, and education portfolio focused on the early interdisciplinary integration of palliative care for patients with advanced cancer. Hello, Dr. Zimmermann.
Hello. Hi, Michael. Thanks so much. It's great to be here.
It's wonderful to have you. Dr. Sarah Hales is a psychiatrist working in the Department of Division of Psychosocial Oncology in the Department of Supportive Care at the Princess Margaret Cancer Center. She is also an assistant professor in the Department of Psychiatry at the University of Toronto. Her clinical and research interests include the end-of-life experience as it affects patients and families, and psychotherapeutic interventions that are aimed at alleviating distress in people with advanced disease. Hello, Dr. Hales.
Hi, everybody.
Well, welcome and thank you all for joining us today. We're excited to hear from both of you about your groundbreaking work in supportive care being done at the Princess Margaret. But before we get started, let me ask you how you and your families are doing through the pandemic. Sarah?
We are very well, thank you. I have 2 small children, and they are on summer vacation break from the School of Mom, and they are enjoying that, as am I.
Wonderful. Camilla?
Yeah, we're doing well too. Actually, my kids are a little bit older. They're in their 20s and all in university, but they came back early and finished off their terms here, and now they've got various summer jobs, and we're all together as a family again, which is actually kind of nice.
Oh, that's terrific to hear. Let me start with you, Dr. Zimmermann. For those in the audience who might not know, what is palliative and supportive care?
Yeah, so I'll start with palliative care, and quite simply, it's just interdisciplinary care that's aimed at improving quality of life for patients with a life-threatening illness and their families. And just sort of to unpack that a little bit, when we talk about interdisciplinary care, it's care that's not just provided by a doctor, but also by nurses, social workers, psychologists, physical and social and occupational therapists, and really a large team that work together to improve quality of life. And when we're talking about quality of life, we're talking about, again, not just physical quality of life, but also emotional care, social care, and spiritual care for the patient and for the patient's family. And when we're talking about life-threatening illness, we're really talking about an illness going to kill you, but for which you might be afraid of dying right from the beginning of the diagnosis. And certainly cancer fits that. As soon as anyone's diagnosed with cancer, the first thing that comes to mind is, oh my gosh, am I going to die from this? So, and what palliative care does is help patients and families all through the course of the illness, not just at the end, to improve their quality of life. And then when we're talking about supportive care, it's more of an umbrella term that includes palliative care, but also includes other aspects. And that's why we have 3 divisions in our supportive care program. We've got palliative care, which I've described. We've also got psychosocial oncology, or what we call our mental health program, where we have psychologists, psychiatrists, and social workers who are helping patients and their families with the emotional strain of the illness. And we have a cancer rehab and survivorship division. So, and this is aimed at recovery from cancer. So what happens after cancer when you're trying to get back on track again? So those 3 divisions are what composes our larger supportive care program.
That's great. That's a terrific overview. Dr. Hales, maybe you can describe to our audience the role within the supportive care team at the Princess Margaret that you deliver.
Thanks. Yes, I am a psychiatrist, so I am within that psychosocial oncology division under the umbrella of the Department of Supportive Care. I personally am a clinician and a researcher, so I divide my time between those 2 roles. And I work within a multidisciplinary team that includes other psychiatrists, psychologists, social workers. We have music and art therapists as well. And we see patients across the cancer trajectory who are struggling, they may need practical supports or resources, or they have psychological distress and emotional needs that need attention. And we also do a lot of support of the oncology teams on the front lines, because not everyone needs to see a psychosocial oncology specialist, but all of our patients need attention to this aspect of their cancer care.
Excellent. I've got a question for both of you, and I'll start with you, Dr. Zimmermann. Palliative care is obviously a lot more than just end-of-life care for people with advanced cancer, but that has been a stigma about it. How are you trying to end that stigma amongst our patient population?
So we're trying to do that in several different ways, and it is obviously a big problem, because the way I defined palliative care at the beginning is certainly not the way I would say patients and their families and the public in general understand it. So, and first of all, what we're trying to do is understand the problem. So we've done a series of surveys and interviews with patients, caregivers, and the public, and also a national survey of oncologists, to understand sort of where this stigma comes from and how they see palliative care. And really, people tend to see palliative care as end-of-life care, as care right at the end of life, as very much associated with death and dying. And it's something that they tend to be really afraid of, which is really too bad, because right when you need the care the most is when a lot of people sort of shun away from this care that could really benefit them. So, and what we're trying to do to change this is really to change the model of care from one of end-of-life care to care that's provided throughout the illness. And I'm just going to tell a short story, because I think it's interesting, that recently, well, not that recently, before COVID, I was at a family event. And of course, we can't have large family events right now, but this was before COVID. And I ran into a friend I hadn't seen for quite a long time. And he said, "So Camilla, you're in palliative care, right?" And I said, yeah, I'm still in palliative care. And he said, "I want to tell you about a neighbor of ours who's in this great program. He's got prostate cancer, but he's still doing fairly well. But he was set up with a palliative care team, and they're treating him along with his oncologist and managing his pain and providing him with support for him and his family, and as well over the phone, so he can call them anytime if he has pain 24 hours a day. Just wanted you to know about that. And I said, actually, that's our program. I'm running that program. So it was really neat to see, from the patient's perspective, that this actually works. And what we're trying to do right now is to spread this model of care beyond Princess Margaret and beyond Toronto and Canada, even internationally. And it is something that's taken hold. International societies are also promoting this model of care. What we need to do now is to have patients and the public in general understand how palliative care can help them.
That's a great story, and thanks for sharing that with us. Dr. Hales, when you think about your role within the department, how are you trying to end the stigma when dealing with patients as well as their families?
Well, I really echo everything Camilla was saying. I think that is true. There is a lot of stigma, particularly when we're talking about advanced disease and how we can both support patients to live with their disease and also prepare if they need to around end of life. We are also really struggling, I think, within our department with the stigma of mental illness itself. That still exists. It's very pervasive. And even within the healthcare profession and amongst policymakers, mental health care is often seen as not core health care. It's an afterthought or it's a frill. But actually what we know is that the psychological and emotional toll of cancer, it's great. It is very common. And the disability and loss is very costly to society. So it's really something we need to approach and treat. And we're big advocates within our department for that.
That's terrific. Maybe there's a rebranding exercise that needs to take place for palliative care. So we'll task the team and get back to you with some ideas. Listen, you've talked about obviously your work with patients and of course by extension their families. But I do know that you both have active research projects that are ongoing. Maybe starting with you, Dr. Zimmermann, you could give us a line of sight on some of the exciting research that you're undertaking, and also where you think it might lead to better treatments or outcomes for patients.
Yeah. So the main focus of my research again is early palliative care, and the most important study that we've published so far is a randomized controlled trial it's now been cited actually more than 1,000 times, and it was published in The Lancet a few years ago. Which was a randomized controlled trial where patients with advanced cancer, but these were patients who were still coming back and forth to the hospital. And we randomized half of them to seeing our palliative care team early in the course of illness, so as soon as they were diagnosed with advanced cancer, and the other half got regular oncology care, and their oncologist could still refer them to palliative care whenever they wanted to. But that tended to be it was about 10% of the patients who actually got referred to palliative care during the course of the trial. And what we found is that the early palliative care group had better quality of life, better symptom control, and better satisfaction with their care at 4 months into the trial. And you might think that's kind of a silly trial. Palliative care is meant to improve quality of life, so we showed it improves quality of life, but no one had actually done that before in a large group of cancer patients. And we had more than 450 patients enrolled in this trial. And it has resulted in huge change, actually, internationally. The American Society for Clinical Oncology put out a guideline saying that every patient should receive palliative care along with their cancer treatment if they have advanced cancer. The European Society for Medical Oncology put out a similar guideline. So really, internationally, this work has had a huge difference. Where we're sort of leaning now is, does everybody need to see a palliative care team, and can we really have everybody see a palliative care team? Because we obviously have a limited number of people, and lots of people with cancer who could maybe use this. So now we're doing, in our next trial, which is funded by the Canadian Institutes for Health Research, we're doing symptom screening and targeted palliative care for those patients who need it. So those are some of the things that we're doing right now.
Great, thanks for sharing. And it's another example of not just the impact they're having for those that are coming to our cancer center to be treated, but the influence that your research is having outside, across the country, and quite frankly around the world. So great example. Dr. Hales, give us a line of sight on some of the work that you're pursuing right now.
Yes, I am interested in the psychological and emotional side of the advanced cancer experience for patients and families. Camilla was on my thesis committee for my PhD when I began 15 years ago, and that project was looking at the quality of the dying and death experience. So Camilla talked about quality of life, which is really broad, includes not just physical, but also psychological and social and spiritual and existential aspects of experience. Quality of death also incorporates whether people are prepared for end of life and attend to life closure. And that study was very interesting for me. It really highlighted the fact that we had a lot of evidence-based interventions to support people around how to manage the physical aspects of their illness. But what we didn't know was how to support patients and families around mortality-related distress. When you're facing an illness that can end your life and the distress that generates, how can we support people? And so from that, with Dr. Gary Roden, who is my mentor, we developed an intervention called Managing Cancer and Living Meaningfully, or CALM, which is a psychotherapy intervention that aims to support patients and families through that advanced disease experience. And that work has really been so fruitful, and we are now involved in translating that across the globe, and it's been very exciting. Another offshoot of that has been, how do we attend to the needs of family caregivers? Because they are also really very affected, particularly by the advanced cancer experience. They're asked to do a lot and provide a lot of practical supports, as well as coping with their own emotional distress. And we see them as sort of the invisible backbone of the healthcare system that up until fairly recently hasn't had a lot of attention.
That's amazing. And obviously, having been at the Cancer Center for the better part of 2.5 years, very familiar with the work that you've done with CALM. And again, another example of how something that's incubated at Princess Margaret is being shared widely. So kudos to you and your team. Dr. Hales, maybe I'll stick with you. Let's get back to your clinical work. I'd be really interested to know how that has changed since really the shutdown with the pandemic that started in mid-March. How's it been working, doing your job and carrying out your responsibilities at the Cancer Center?
Well, it's very different. I mean, I am wearing scrubs today, which is very unusual for a psychiatrist. So that has challenges, wearing face masks and face shields while you're trying to provide psychotherapy to patients at the bedside. We're doing a lot of virtual care. Almost all of our outpatients we're seeing virtually. And I've always done a lot of that as a psychiatrist, but now we're doing that pretty much uniformly. And patients and families are really appreciating it. It is very difficult to come to the hospital for repeated appointments when you're unwell. So that I think they like, and they want us to continue. But there's a lot of challenges, I think, particularly around equity of access, because not everyone has access to a computer with a good online access. The other interesting thing that we've been involved in is, as I said before, supporting our frontline oncology colleagues. I think people are aware of the fact there's a lot of distress within the hospital. Healthcare providers are worried about their own well-being and safety, but they're also having to deal with the emotional distress of patients and families. Especially with our restrictive visitor policies. People are having to cope with cancer, their appointments, and inpatient care on their own. And so we've been involved as part of a program called CREATE, which was spearheaded by Dr. Mary Elliott, who's a psychiatrist in our department. We've been paired with different oncology teams and trying to support those frontline teams in coping with their distress and better supporting their patients.
That's terrific. And again, kudos to you and your colleagues at the Cancer Center for having to adjust and make a lot of different pivots, as well as leverage technology to better treat our patients during this pandemic. Dr. Zimmermann, let me turn to you and ask you, this is the 4th webinar that we've had, and I think in every one of them so far, there's been lots of discussion about the use of data science and how it's going to inform research as it moves forward. I'd really be interested to know what you think the role it could play in palliative and supportive care.
Yeah, so data science is basically using these large databases including with artificial intelligence, to make predictions and decisions about the clinical care. And the main way that we're doing that in supportive care is through collecting data about patient-reported symptoms. So we're interested really in the patient experience of cancer. So we collect routine data at the hospital when patients come in about their pain, their shortness of breath, their nausea, etc. And so far, it's mainly been in the hospital. We're moving now towards, and they're doing this in the US more and more as well, towards collecting this information through smartphones at home or wherever patients are as well. So that, as Sarah was saying, patients don't actually have to come to the hospital to provide this information. So, and the next step really is to couple that with triggers. So what we're doing in this new research project is that if a patient reports a symptom such as pain that is moderately severe through their cell phone app or through the information they're completing at the hospital, then an automatic alert is sent to a nurse who will call them and actually discuss those symptoms, and also discuss whether or not they might want to be referred to palliative care. And that's the next funded study, actually, that we're doing right now. So this targeted approach, not approaching everybody for early palliative care, but approaching those patients who have the most severe symptoms.
Excellent. Dr. Hales, is there anything you want to add in terms of how you see data science informing the research that you have undertaken?
Yeah, I agree. I mean, very much what Camilla is talking about in psychosocial oncology. We have a program spearheaded by Dr. Madeline Lee, who's one of our psychiatrists. It's called DART, Distress Assessment and Response Tool. So that's in the clinics. And so every patient is screened about their psychosocial distress and support needs. And that is then becomes an enormous database of patient-reported outcomes that we can look at, and we can kind of link to aspects of treatment. So alongside this patient record, which has always been really the story of the cancer and its treatment, we have the patient experience. And I think the next phase of that is, as Camilla was saying, putting a lot of this online so that we can have it, collect that information when patients aren't physically in clinics, and also expanding it to caregivers. Again, I'm really an advocate for attending to the needs of caregivers. And if we don't ask caregivers how they're doing, we might never know. And so we want to be able to screen them as well and collect information about what the cancer experience is like for them.
Excellent. Let me stick with you, Dr. Hales. I know that a lot of your work is focused on the importance of emotions and what is normal in the context of a serious illness. Can you elaborate on that and provide us some more insight?
Sure. It's true. I spend a lot of time talking to people and telling them that they're normal. Unlike a lot of psychiatrists, I see a lot of people I certainly see people who have psychiatric illness, and that can complicate their cancer treatment, but I see a lot of people who would never normally see a psychiatrist or a therapist. But they are experiencing really profound distress, whether it's due to the diagnosis or progression of disease or new symptoms or the losses that come with that experience. And they need support and education. And they need it often too because their informal network is itself distressed by the cancer. So their loved ones are also grappling with their distress. So they really need support. We know that they will adjust in time, that's human nature. And actually, we're far more resilient than we often realize. But they need that support. They don't always need it from a specialist, but they need it from somebody involved in their cancer journey who sees that as part of the picture. I think as cancer care becomes more advanced, it's often more technical. And certainly now with COVID, everything is virtual. And sometimes what gets lost amidst the busyness of our cancer hospital is the whole person. Who is the person? Who is the family that are sitting in front of us? And so again, I see our work as really advocating for attention to that, not just pathology, not just what might be on the fringe in terms of an abnormal or pathological response to cancer.
Excellent, thank you. A question for both of you, and I'll start with you, Dr. Zimmermann. You guys have actually both given us great examples of some of the international, or some of the work that, again, started or was incubated at Princess Margaret, and then obviously is having impact elsewhere. How do you both tap into your global networks to help inform clinical care and research at Princess Margaret? So as much as we're giving, how are we leveraging what we're learning through your networks to help deliver better patient outcomes here at Princess Margaret?
So I think the first way it's through society. So our team is very involved not only with the Canadian Cancer Society, but also with the, as I mentioned, with the American Society of Clinical Oncology, which is the largest clinical oncology society in the world. And just through my work in palliative care, I've been involved in several of their supportive care guidelines. Right now, I'm working with them to develop a guideline for what's called vertebral augmentation. So like a cement-like substance is injected into the spine to stabilize the spine and to improve pain control in the spine. So it's just one of the projects that we're working on right now. I'm also very involved with the European Society of Medical Oncology, and I'm presenting at their international meeting this year. It was supposed to be in Spain. Now it's, wherever we happen to be online. Presenting on what I was talking about earlier. So really teaching oncologists about palliative care. So a lot of the misconception about what palliative care is actually comes from within the medical system, because oncologists, oncology nurses also see palliative care as end-of-life care and haven't really been taught on how to provide the kind of physical support and emotional support that happens in palliative care. And specialists can't do everything. So we're working as well on educating oncologists about palliative care and how to provide it. We also have developed collaborators really all over the world, including in India and in Mexico. And again, they're using our model of care and developing our model of early palliative care in their cancer centers. They have a huge cancer center, the Tata Memorial Cancer Center in India. We're working with them, and the National Cancer Institute in Mexico as well. And I went to both of those places again before COVID. But now we're meeting very regularly via Zoom or also via WhatsApp. And having regular research meetings with them as well. So it's really quite kind of neat to be able to have this kind of international research group that's furthering an agenda that's considered important really all over the world.
Well, that's great oversight and a lot of detail. I'm sorry that you won't be going to Spain this year, but we'll see if we can't get you a backdrop of Barcelona
Yes.
during your conversations. Dr. Hales, the same question to you. How have you been able to leverage your networks to not just share the success that the program's had here, but also how does it inform and evolve what we're doing at Princess Margaret?
Yeah, all of my colleagues are involved in a lot of international work here, but the program I'm most involved with is CALM, and we have a global CALM program now. And we have groups in over 20 countries, every continent, involved in development of CALM in their settings. And what this has allowed is then for us to, with them, alter, improve, and change the intervention to better, I think, meet the needs of different populations. I mean, as you know, Toronto is the most multicultural city in the world. And so that has been really, I think, very valuable in terms of making sure that this is an intervention that's applicable to people, from various different cultures and backgrounds. And Camilla is right, we can't travel anymore right now, but having planted all those seeds, we are meeting all the time via Zoom, and we have ongoing both clinical supervision of clinicians in these sites around this intervention and developing their skills, but also supporting researchers in those sites, and then collaborating and sharing information. So it's incredibly exciting. It's international research, which is it's tough to do, but incredibly rewarding and really unique.
No question. And certainly at the end of the day, great for our patient population to be able to draw on what's happening around the world, because I think we all agree not everybody has all the ideas, and it's going to take those networks and those opportunities to collaborate in order to move the needle. So well done to both of you on both the domestic front and the work that you're doing internationally. Dr. Zimmermann, maybe I can ask you, since you head up the department, we'd love to know what is your vision for the program, and where do you see it in the over the next 5 to 10 years?
So I really think we want to be at the forefront internationally of research, of education, and of clinical care in mental health for patients with cancer, in palliative care for patients with advanced cancer, and in cancer rehab for those patients who are getting well from cancer. And I think we're already achieving that actually in many ways, but I think we can go further. In particular, I think we need to develop outstanding models of clinical supportive care. I think we're already at the forefront in terms of innovative ways of providing care. I think we could do better at transition points, particularly when patients are going from the hospital to the community, or from the community to the hospital. This is a problem really not just with palliative care and advanced cancer care, but really for cancer care in general. We need to avoid sort of bottlenecks and make sure that patients receive the right care in the right place at the right time. We also need to be at the forefront of education in supportive care. We have a wonderful fellowship program. Right now, it's most developed in our palliative care program. We have 6 fellows who come literally from all over the world. It's a very competitive program. We had 26 applicants last year for these 6 positions. And we have people who have come from France, from Ireland, from Israel, Egypt, Mexico, South America, from Brazil, from India, Thailand, and South Korea and other places, to spend 1 clinical year or 2 years if they want to do research as well with our team, and to learn from us as experts. And it's really been, I mean, as you can see from the fact that we have more than 20 applicants for these 6 positions, it's been incredibly successful, and has become really, we're the only program really worldwide that's doing this. So I'd like to expand this to also psychosocial oncology and to our cancer rehab group, so that we have really a large group of fellows who are learning in, as Sarah was saying, the most multicultural city in the world is the appropriate place for this kind of international education to be happening. And then what they do is they bring their knowledge back to their own countries. We remain collaborators with them, and are involved in research on an ongoing basis with them. And they become leaders in their own countries. And then the third way is through this research. We have great funding for research, I think, at a national level in terms of basic science, not as good at the federal level for supportive care. And we need more research, including in clinical trials for cancer pain, for cancer fatigue, for psychosocial distress, and again, for rehab, including exercise therapies, for example. So in all these 3 areas, clinical, education, and research, we want to be at the top of our game. And we're I would say almost there. And I think in the next 5 or 10 years, we can certainly be there.
Well, that's great to know, and very encouraging. Before we go to the questions from the audience, one last question for both of you, and I'll start with you, Dr. Hales. What are you doing to stay healthy and decompressing during this pandemic?
I find that spending time with my children is the best break, getting immersed in their world. So this past weekend, we painted stones that we'd collected on the beach, and they spent about 10 or 15 minutes doing it, and I was there for 2 hours. And I now have a collection of painted rock fruits and vegetables that is very satisfying.
That's awesome. That's great to hear. And Dr. Zimmermann, what have you been doing to decompress during the pandemic?
So as well, I've been enjoying spending more time with my kids. As I say, they're all out of the house usually, so having all three of them at home has been actually a real treat. We have a standard poodle as well, so we go for long walks with the dog. And I run. I run at least 5 kilometers 5 days a week, either before or after work, which helps me to unwind.
Very nice. Now you're making me feel very guilty. Sitting on the couch. That's how I'm decompressing these days. Well, listen, thanks so much for taking the questions we had, and now we'll turn it to the audience, and here we go. So just give us a moment here. So let's start with the first one. In a large, somewhat industrial, perhaps of necessity, setting such as Princess Margaret, what can be done to address the overwhelming sense of powerlessness and sadness many patients experience? Thanks for being present for so many patients in this situation. Dr. Hales, maybe we'll start with you with that one.
Well, I absolutely agree with you that this is something we need to address. And as I was saying, I think this is really our job in psychosocial oncology, is to be advocating for the patient experience. It's an unintentional, all people go into cancer care because they want to help patients. But as care gets more technical, and as people get busier, there's less and less time and attention spent focused on the patient and getting to know them. And for most patients, even if we can't prevent all of their distress, being unknown and understood is incredibly helpful for them, being seen and recognized. And so that's basically the essence of the work that I'm trying to do. I can't take all that sadness and powerlessness away, but I can provide a lot of support. I can provide education and help people get through it. So that's really my mission.
Excellent. Dr. Zimmermann, do you want to add anything to that?
Yeah, I think especially during COVID, it's been an extremely isolating time for patients. Again, as Sarah was saying, due to the restricted visiting hours in particular, we're getting a lot of distress from families not being able to visit. I think, the essence of palliative care is that it's not only patient-centered, but also family-centered. So keeping the family in mind and keeping the care centered on the family has been extremely important. And we have been advocating and working with the hospital. Obviously, we want to keep patients safe and keep our society safe, but we're trying to strike a balance between that and also allowing family members to visit in a safe way, especially around the end of life. But it has been a really difficult time for everyone. As Sarah was saying, we're also providing a lot of care over the internet and over the phone. So we've always done that, but in palliative care as well as in psychosocial oncology, about 90% of our care became over the phone. It's actually been a really good teaching experience for us that it is a valid way to provide care, to do the whole appointment over the phone if that's what is convenient for the patient at the time. And many of our patients are very ill, and then this is what we should be doing. So keeping the patient and family in mind and making sure that everything we're doing is centered around their goals and their values.
Yeah. Thank you. This next question, which I think is critical, and unfortunately having late last year, having to care for my late mother who had pancreatic cancer. It's not just the journey of the patient; it's the whole family. And I think the question around caregivers or that family support. What specifically, and maybe I'll ask you this, Dr. Zimmermann, what specifically are we doing in addition to treating the patient and supporting them through their cancer journey? what do we have in place to help the caregivers that are there throughout all of this? And in many ways, it can be just as hard, or maybe it's a different challenge, but it can be just as challenging for them as they see their loved one go through cancer treatment.
Yeah, so I mean, there have been, and I'll let Sarah address some of this as well, because she's very involved in our caregiver clinic, and our caregiver clinic is under the Psychosocial Oncology program. So we have a specific clinic that is just for caregivers and addressing their needs, which is as well available through online support as well. But just in general, there have been studies and publications showing that caregivers have as much or even more distress, and by that I mean anxiety and depression, than the family member. They're there for every step of the way. They're providing hands-on care, and they're being the advocate as well for the patient. They come with them to their visits. And they're providing really hands-on care. We unfortunately, don't have enough home care, I think, in the home. So often they're doing really everything, including very hands-on support that could be done by personal support workers as well at home. So a lot of distress for caregivers. The caregiver is a part of the focus of care in palliative care. So, and really it's family-centered care. So the care is not centered only on the patient, but also on the caregiver. Usually caregivers actually come to the palliative care appointments. I always make a point of involving the caregiver in the conversation. They're not only, members of the family, but they're also care providers. They're actually providing hands-on care. So their perspective is extremely important in terms of letting us know how the patient is doing. But it's also important to ask them how they're doing. Often the caregiver is the silent person in the room, and no one's asking them how they're doing. So I make a point of asking caregivers how they're doing. And then also pointing out that we do have this caregiver clinic, which is specifically geared at caring for caregivers. And I'll let Sarah know a little bit, Sarah tell you a little bit more about that.
Yeah, I would echo everything Camilla is saying, and this is absolutely something I'm really passionate about. I think it's true. I think caregivers don't get the attention that they need. Again, it's seen as sort of an afterthought. Our whole healthcare system is designed with a patient. Even the electronic patient record has the patient as who's receiving care, and there's nowhere to even document that you've spoken with a family member. So I really think this is so important, and our healthcare system, when you think about it, it cannot run without informal care. And if you meet patients who don't have a support system, they really struggle to go through cancer care. It's very complicated, and you need people to help you with it. So I absolutely agree. We have a caregiver clinic now that we've started that's been supported by foundation money. Dr. Renat Nassim is a psychologist who works with us, and she and I are involved in that clinic and doing research in order to increase the profile of the needs of caregivers and think about interventions that can meet their needs. It's tricky because, as you might guess, caregivers are hard to reach. They are very busy caring for patients, and so they often don't have time to come for appointments for themselves, and often have a lot of guilt about even taking resources for themselves. So we have a lot of education to do, I think, and thinking about novel ways to access them and support them. So that's something we are researching and looking into.
Excellent. We have a question which ties into the whole space transformation campaign that's going on right now at the Princess Margaret. Actually, probably about a year ago or so, we opened up new palliative and supportive care space. And one of the questions that we're getting from the audience is, how has that new environment improved both the ability to treat and deliver services to our patients, as well as the experience that they and their caregivers are having? Maybe Dr. Hales, you want to take that one?
Well, actually, I don't get to work in that clinic. I want to. It's beautiful.
I can take that one.
Sure.
It's our palliative care clinic. It's had a huge impact on the care that we can provide Before, just to take you back a few years, before we had this wonderful palliative care clinic, we were borrowing space from medical oncology. So we were like an itinerant clinic. We were in borrowed space in the GI clinic one day, in the lung clinic one day, in the prostate clinic the next day, breast clinic the next day, this kind of thing. Borrowing space where we could find space. And often the space that these clinics were generously providing for us was actually not big enough. So we weren't able to see the patients that we needed to see in the clinic. So we had long wait lists as a consequence. So now that we have our own space, patients are being seen in a space that is appropriate to them, that has been custom designed for them, that is comfortable to be seen in. Also, it's important to mention that before, when we were borrowing space from other clinics, if you were a prostate cancer patient, you might be seen, for example, in the gynae clinic, which is a bit weird for someone with prostate cancer to be going to a clinic that's marked gynecology. So now they're going to a clinic that is an outpatient palliative care clinic. We have enough space to see them. It's a custom designed, beautiful, airy space. And our patients are grateful, their caregivers are grateful, and we're also very grateful as the providers in that clinic.
Terrific. Well, listen, we've got a few more minutes. So just first of all, I've just got somebody posted just a compliment to you and your team and the great work that they're doing, especially recognizing the role that caregivers play in someone's cancer journey. So thank you. Maybe what I'll do is one question here, and perhaps if you can answer it, I think it'd be important because somebody I think is reaching out. They've been looking and have not been able to find support groups for patients at Princess Margaret. And I'm wondering specifically around someone who is dealing with lung cancer that has metastasized to the brain. Is there any I guess anything that you could provide that individual that submitted that question?
Yeah, so it's true we don't have as much group support, I think, as we could. And I think that's something we would like to develop more of. It's a very efficient way. I don't think it's instead of individual support. I think it's often a complement to it. So we actually partner a lot with other organizations. I think there was a question on here on the Slido about Maggie's centers in the UK. And so we have colleagues that through Wellspring Centers in Ontario, Gilda's Club. These are some really wonderful cancer support programs outside of Princess Margaret's walls that can continue and provide complementary care to the kind of care that we provide, which tends to be very often very individual and family specific. So I would try those organizations, and they might, even if they don't have a group that's specific to lung cancer metastatic to the brain, they do have support groups for people with metastatic disease. So I would reach out to those and check them out.
Great. Well, listen, that's tremendous advice, and really appreciate you sharing that with us. Well, I'm afraid that's all the time we have for questions today. We really appreciate everyone who submitted or voted on questions for the session. And of course, on behalf of our foundation and our audience today, we want to thank Dr. Zimmermann and Dr. Hales for engaging us in your important work. It's clear that you're passionate for helping your patients and their caregivers, which drives your high impact research. Because of your team's work, supportive care is internationally recognized as an integral part of the patient's cancer journey. And thank you for joining us. I hope you enjoyed today's session, and we look forward to seeing you at a future Princess Margaret Foundation virtual event. Remember, there is a donate button below on your Slido page. Please consider supporting the Princess Margaret Cancer Foundation. Until next time, take care and be well. Thank you so much.
Bye.